We're going to move on to our next session where we're going to talk some more about some of our theme on vulnerable populations. In particular, we're going to start talking about child and adolescents. And I think, Phil, you're up first. So welcome, Phil Britton.
For all those who are persevering to the end, congratulations. I've got total imposter syndrome in being here. This is a cohort that was set up in 2015 and proceeded to mid-2018. And I really think what's going on here is Ben Murray, in his kind way, has invited me to give a talk in order to kick me up the bottom to finish the project. Only Ben can do that in his nice way that he does. So I do apologise, this is sort of a relatively old data set, but I'm a humble clinician and I'm interested in individual patients, so some of that will come through. It's kind of a bit weird not being able to see slides, isn't it? All right, here we go. So you'll all know that child TB in Australia makes up a small minority of TB disease, and there's been a few studies now, largely small case series, except for the paper from Stephen Teo and Steve Graham, which looked at notification data published in 2015. But really, having done a few small clinical case series, we thought it would be a good idea to collect a national cohort to look a bit more in detail clinically at children. And so that's what we did, and set up this database of children's hospitals around the country to collect really an enhanced clinical data set from cases of child TB presenting to our hospitals. And between 2014 and 2018, the data set has in the end contained 144 cases of child TB in Australia and from one side in New Zealand. And with respect to its representativeness, it accounts for somewhere between 35 and 45% of child TB cases under 15 in New Zealand and Australia for that time period. We did collect cases up to the age of 18, but because of the nature of children's hospitals and their admission kind of age ranges, between 15 and 18, we have a significant reduction in numbers relative to notification numbers. In fact, just to say, these cases were recruited from hospitals around the country, except in Queensland, where Ellen Donnan, who's here, did all the hard work to pull the case data from across the state. And that's an important point to make, because it is important to some of the findings. So we do have a large data set, both including demographics and risk factors and clinical presentation, testing, and outcome data on a majority of our cases now. And a few things come through that I just wanted to point out today. The first is that really the Pacific Island ethnic group in Australia is really profoundly overrepresented in child TB, and half of this is really cross-border disease in far north Queensland, and again there's the bias in terms of Queensland's recruitment of cases, but actually this overrepresented ethnicity is found in all eastern seaboard states, and it just speaks to the specificity, the social and economic specificity of TB wherever you are in the world. And for those of us in New South Wales, and Stephen Corbett's here, in Western Sydney, this is really a big issue in terms of TB control, is the Pacific Island group. Aboriginal and Torres Strait Islander Australians were not significantly overrepresented, though we acknowledge that we weren't recruiting from the territory for most of the period of the time. The other thing that comes through is that child TB is quite different in New Zealand to Australia. So in New Zealand, a minority of cases have parents born overseas, whereas in Australia, the vast majority of children have parents who were born overseas, and speaks to an endemicity of TB in certain ethnic subgroups in New Zealand that's not as clear in Australia. Travel is an important factor in child TB, and 40% of our cases had travelled to a high TB incidence country in the previous 12 months. The other thing that's important is that a reasonable number of cases where we have the data had a known TB contact in Australia or New Zealand. Now, it's more common in New Zealand than in Australia, but a significant subgroup, and 20% of child TB, of the cases of child TB we identified, had a contact in Australia and acquired TB in Australia. So where we're interested in TB elimination and where children are acknowledged as an epidemiological marker of transmission, we still have room to move in terms of reducing acquisition in children of TB in Australia. In terms of clinical presentation, this is the distribution of what you see. Cough and fever, as we'd all expect, are up the top of the list, but TB, is the great mimic, can cause anything, and so you have a very long tail of the clinical symptoms that could present. Median duration of symptoms in children is relatively short, 3 or 4 weeks, cough and fever. And if you look at the breakdown of disease, 2/3 is pulmonary, about 1/5 extrapulmonary, and in children, a quarter involves both pulmonary and extrapulmonary sites, and 50% were bacteriologically confirmed, much more likely in pulmonary TB than in extrapulmonary TB. This figure just shows you the breakdown of really extrapulmonary TB by age group, showing in the, I think it's burnt orange is the university colour, isn't it? The burnt orange and the less burnt orange, you see really disseminated and or miliary TB and central nervous system TB, and you see this classic distribution of disseminated and miliary TB and TB meningitis being overrepresented in the youngest age group, and in fact in young children extrapulmonary TB was always disseminated in this cohort. And if you look at the association with disseminated TB or TBM and BCG receipt in our cohort, you see that BCG receipt is associated with a significant reduction in the odds of disseminated or TB meningitis. Interestingly, the opposite relationship is true with TB lymphadenitis, where you see this increased odds ratio of BCG receipt, which I haven't really got my head around yet, but that's what we see. So in terms of diagnosis, this just gives you the detail on TB diagnostics in children in Australia and New Zealand. We see a diagnostic yield of culture of 69% from respiratory samples, on microscopy 42% on respiratory samples, and PCR of 65% on respiratory samples. Now this is dirty data, of course, because not every kid gets sampled with every sample, and PCR is very selectively used in our cohort. But it gives you a sense of the yield, the culture and PCR yield of specimens in children. In terms of chest X-ray in children, you can see that lateral chest X-ray, despite a reasonable amount of advocacy for the importance of lateral chest X-ray in terms of diagnosing high-low lymphadenopathy in children, it's very infrequently used in Australia and New Zealand. And in terms of the pulmonary TB phenotype, we see this predominance of lymph node disease in children, a third of which are associated with some sort of lymph node complication. The next most common phenotype was pleural effusion, and only 10% of children had cavitation, and huge numbers of non-chest X-ray imaging that were too difficult to go into. Outcomes, we have complete outcome data on 114 of the 144 children. Of those with drug-sensitive TB, a quarter received 3 drugs in their acute treatment. 3/4 still receive 4 drugs, and I think there's room for improvement in that area in terms of the necessity of ethambutol in child TB. 2/3 of children received pyridoxine, and again that's a debatable issue too. Adverse effects are infrequent in children, only 12% with an adverse effect that was reported to us. biochemical hepatitis being the most common, or gastrointestinal effects. Only one child with blurred vision, but that was a child on ethambutol and probably unnecessarily. And rash is very uncommon. There was one death in this cohort, a young child with disseminated disease. Yes, I'm thinking the right case. The vast majority of children were completed or cured or on treatment, but because of the far north Queensland cross-border population, there was a small number of children who were lost to follow-up. So the two clinical groups that are most interesting to me are the meningitis group and the MDR group. And so just to give you a bit of a clinical flavour, here there were 16 children with tuberculous meningitis in our cohort, 4 of whom had isolated TBM, but the majority had pulmonary TB as well, which is interesting, a little bit different to what's observed in other populations. 4 of those children had tuberculomas on imaging. Only 11 of 16 children were given corticosteroids with initial treatment, so there's room to improve there for clinicians in Australia. And moxifloxacin was used in a couple of children in preference to ethambutol later in the cohort. And there was one case of MDR TB meningitis treated over the 4-year period. There were 7 children with multi-drug resistant tuberculosis. That's 4.8% of the cohort. Obviously, by recruiting in children's hospitals exclusively, we're biasing to finding these children. 4 of these children were in Queensland and all associated with having parents either born in or they themselves being born in Papua New Guinea, the so-called cross-border children. But there was one in WA, one in Victoria and one in New South Wales. 5 were microbiologically confirmed. The 2 that were clinically diagnosed were children in far north Queensland with an adult contact with known MDR TB and were treated on the basis of the isolate from the adult. 2 pulmonary TB, 2 extrapulmonary TB and 3 with both. 6 of 7 children were given an injectable for 6 to 8 months. And so, obviously there's a lot of movement in this space around non-injectable regimes, and there's some education that will need to be done for Australian clinicians. Not that this is a common thing, of course. 5 of the children completed treatment, 1 was on treatment and 1 was lost to follow-up. Adverse effects were clearly much more common, but actually only 3 of 7 children had a significant side effect. So, of course, this is a small number of cases, but it captures what's observed elsewhere, that children tolerate the complex medications of MDR TB treatment much better than adults. But tragically, 1 child had permanent sensory neural hearing loss from long-term amikacin use. So, obviously, I'm presenting to the people who gave us seed funding, so it's always good to say that we did do something. So a few things that have come out of this. A couple of the case series that I mentioned at the start arose from either the genesis or the actual delivery on this project. 2 trainees got their college advanced training project from this data set. We did submit a report to the National TB Advisory Committee in 2018, and that was well received. I wasn't there, Ben was there. This Dataset was analysed for a paper in 2019 for the Australasian Society of Infectious Disease meeting, and that's when I should have written it up, but I do apologise. Let's call it a collateral damage of COVID. And we were able to contribute to the European Child TB group in a paper where they were looking at TNF inhibitors and TB in children. When I say contribute, we were able to say to them that we hadn't identified any children in Australia and New Zealand with TB on infliximab or other anti-TNFs, but that helped them at the time. And there are other international opportunities in the space of MDR TB and TB meningitis where we may be able to contribute small numbers of cases into bigger analyses. So that's all I wanted to say, and hopefully that's caught up a little bit of time for Steve, who's going to be much more interesting.
We have time for a quick question or two if there is.
Hi, I'm predominantly an adult respiratory physician, but through our clinics we do manage some paediatric cases. Just had a question regarding delay in diagnosis. What we've seen in South Australia, often with children, is that there's a significant delay between first clinical presentation, usually to their GP, to diagnosis of TB. Was that a finding that was quite common across the paediatric cohort that you looked at?
Yeah, so it is a good question. We actually collected, because we were interested in this healthcare utilisation issue, and we did collect first presentation and to which health service, as well as admission, length of stay reasons and all. I haven't actually looked at time, duration of symptoms for those who presented initially to GP versus somebody else. I'm not sure we'll have much power, but it's worth looking at. But absolutely, the vast majority of these children go to their GP first. And so for early diagnosis, there is a need to educate primary care about child TB. I don't think your average GP in Australia thinks about TB at all when they're seeing children. So I'm sure it does contribute to delays, and I've got anecdotes, but we haven't looked at the data in that way.
Hi. You mentioned your concerns potentially about the use of HREZ in the paediatric population, but I was just wondering, with the recruitment up to 18 years of age, how many of those sort of were more tending toward adolescent adult type TB, in which case it might have been warranted, or more the younger age groups?
Yeah, good question. Again, the breakdown I didn't present to you, but only 10% of our cases had cavitation on chest x-ray, and that would probably be the only group that we'd strongly recommend a fourth drug for pulmonary TB. All other groups we would suggest just 3 drugs. So there still is, I think, an overuse of ethambutol in children who have porcine bacillary disease, and that's why they don't need it.
Cool. Thanks very much, Phil.